Okay, good evening, everyone. I'm Imad. I'm pediatric oncologist from Libya. I'm so glad today to moderate first session of this education and training program. I will give the few statement about this education and training program. We announcement coming series lecture organized by Stripe Africa Education and Training Committee focusing about basic pediatric oncology. Today it will be, this is the first module starting from today, 15th of January, and continuously every Wednesday until April, except next Sunday we have on 19th of January a lecture. The time of the lecture will be the same time by 7 p.m. by Central African time. This lecture will be designed to provide healthcare professional with comprehensive foundation in pediatric oncology, covering essential topic in diagnosis and management children with cancer. This is weekly lecture will be given by expert speaker from across the field, and I believe this is very great opportunity to strengthen our knowledge and skill regarding pediatric cancer care. Um, I invite all the participants to join us in this informative session and contributed this session and program with your colleague and encourage them to attend, and all the participants achieved 80% or more from attendance will award certificate. Please, there is a registration form will be in the chat room. You can fill and email it, and any question you can writing down, and will, if you have time by end of the session, we'll answer this question or raise your hand. And we're starting now to introduce our speaker. We're so glad today we have Prof. Ying Zou. Prof. Zou, Associated Professor of Pathology and Genetic Medicine at John Hopkins University School of Medicine. Prof. Zou, distinguished expert and leader in field of genetic and genomic abnormalities in patients with cancer and congenital disease. Prof. Zou currently, she is the Director of Cancer Cytogenetic Laboratory and Cytogenomic Research Core, and she is Associated Director of Molecular Diagnostic Laboratory of Johns Hopkins School of Medicine. Prof. Zou, she is deeply involved in both research and training future leader in genetic medicine. We appreciated, Prof. Zou, today your time and giving us the lecture and stage for you for the lecture. You hear us? She's Prof. Is the Prof with us in the room or not?
Dr. Ying hasn't joined yet.
Okay, shame.
She's having a problem getting in.
Okay,
Do you have a
is someone help her to get? Is someone to or not? Hello, good morning, bro.
Good morning.
Hi. Yes, good morning. I'm Imad. I'm pediatric oncologist from Libya. I'm moderated today's session. We appreciated your time today. I'm sure you good morning.
Good morning.
Yeah, okay. We so glad today we have you and to give us decision regarding cytogenetic and cytogenomic in pediatric children with cancer. I introduce you to the group before you join here, and the floor for you. You can starting your lecture.
Can you see my, let me see whether you can see my screen.
Yeah, we can see your screen. Just make it, yes, it's great now. Yeah, you can see.
It's great. Okay, that's great.
Yeah,
Thanks.
okay,
Yeah, can you hear me?
okay.
Okay.
Yeah,
So,
we can see you and hear you. Nice.
okay, cool. That's good. Thanks a lot for the invitation. Let's talk about cytogenetics in pediatric cancers. So this is my disclosure, which is not associated with today's talk. So today I will describe a common clinical routine method for our cancer patients. And I will review the chromosomal abnormalities in pediatric hematological malignancies. And finally, I will brief mention So we all know the DNA double helix, so it's very pretty, and they can form these beads on the structure. So those are the DNA wrapping on the proteins, mainly histone proteins. So then after the supercoil and the coiled structure, eventually the DNA can pack into this beautiful chromosome. So the middle of the chromosomes is a centromere, which connected the sister chromatids, and the tip of the end of the chromosomes are telomeres, contains the TTAGGG sequence, and which can protect the chromosomes to recognize the DNA damage. And the short piece of the chromosome on is called the P-on, stands for petit, means small, and the long on is we usually call them Q-on. So in order to see chromosomal abnormalities, we routinely using conventional chromosome analysis or karyotyping, fluorescence in situ hybridization or FISH, and the SNP mic arrays or chromosomal mic arrays for our methods in detail. So karyotyping is a single cell analysis and can see the whole genome analysis in a single test. So it can detect different types of the chromosome abnormalities, both numerical chromosome abnormalities and structural chromosome abnormalities. It can provide diagnosis and prognosis, and also can monitor the treatment and disease prognosis. So this shows you the procedure of the chromosome analysis. So the points I want to make is in order to do the chromosome analysis, you need to have fresh samples. And you need to have, when the sample arrive at the lab, we need to put the mitogen, and the mitogen can stimulate the cancer cells grow. And this culture can last about 24 hours or 72 hours. So many mitogen need some time to work. And therefore, it usually takes about 7 to 10 days you can get a chromosome result. So we use the Giemsa staining to stain the chromosomes. So chromosomes can stain with G positive or G negative. So basically in here, you can see the dark band we call the G positive, and the light band we call the G negative. Depends on the DNA content. So for example, the G positive bands, you usually have many repeats, few genes, and AT rich. And the G-positive bands usually has many genes, few repeats, and GC-rich. So generally speaking, loss of the light band usually is associated with worse severe phenotypes compared to loss of G-positive bands. So humans, we are human, we're diploid. So we receive one copy from the mother, the other copy from the father. So we have 24 autosomes, one sex chromosomes. And based on those light and dark bands, we can recognize which chromosome is which. And we also can recognize the structure abnormalities. So in summary, the conventional karyotyping allows a full genome analysis at the single cell level, but at a relatively low resolution is about 5 million base pair. And it is a way we usually use for our cancer patients. So let me introduce the fluorescence in situ hybridization of fish. The fish principle it shows here. So basically you will have DNA genes, so if you're interested in a specific oncogene or tumor suppressed gene, so you can label this gene with a specific fluorescence dye. In here is a red color. So then you can hybridize to your patient sample. So because of the identical sequence, this gene will labeled with a red fluorescence. So the presence of this red color in the patient sample means the presence of this gene. So there are different types of the fish probes showing here. So you can have the whole chromosome painting probes to painting the entire chromosome, or you can have a centromere probe to label a centromere, or you can have the telomere probe to label the telomere. And importantly, you also can label a locus-specific region, such as oncogene or tumor suppressed genes, or any genes you are interested in with a different dye. So furthermore, it's very easy to see the abnormality. So in here, basically the green color is for chromosome 21 and the red color is for chromosome 13. So as you can see here, you have 3 green and 2 reds, and which means you have a trisomy 21, which is easy to see. So the fish is very, very specific. So, and with a high resolution is about 100 kb. But the fish is not a whole genome analysis. So which means you have to know what kind of things you want to see. You have to say, okay, this is a gene, I want to do the fish on it. So therefore, we use the fish commonly for the patients, for the follow-up patients, which we know the patient has this abnormality. So another method we use commonly in our cancer lab is chromosomal microarray, so or CMA or SNP microarray. So the principle of the microarray is based on the comparative genomic hybridization as shown here. So basically you have a patient DNA you label with green dye and the normal control DNA you label with red. You mix the equal amount of the red and green together, and you put them together into a chip. So in this chip contains many, 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 many locations and many, many regions. So each dot here corresponds to a specific genomic location. So a laser can precisely scan the intensity of those probes. And then they can map each dot into a specific genomic location. So in here shows you, a result, an abnormal result between the chromosome 6 and the chromosome 10. As you can see here, you have many, many dots here. Each dot actually is a probe. So you can see here, you have many, many dots here at 2 copies. But however, at the tip of the long arm of chromosome 6, you have 1 copy. So this is a loss of the tip. And in here, this is a chromosome 10. You can see majority of a chromosome 10 has 2 copies, normal 2 copies. But however, at the bottom and the long arm of chromosome 10, you have 3 copies. So which means you have a game of the tip of the long arm. So it's pretty easy to see. So SNP microarray can provide a high-resolution analysis of the genomic imbalances, such as gain or losses. And furthermore, the SNP microarray doesn't need the metaphase cells. So any fresh frozen cells, you can do the microarray. So the drawback for the microarray is you cannot detect any balanced chromosomal abnormalities, such as translocations and inversions and insertions. So chromosomal abnormalities are important in the pediatric hematological malignancies. So leukemia can form in any stage of the cell differentiation, as shown here. So you can have a bloodstream, you can differentiate into the myeloid and the lymphoid. And the myeloid stem cells can further differentiate into the red blood cell, platelet, and the white cells. And lymphoid, you can have a lymphoblast, and B lymphocytes, T lymphocytes, and the nature killer cells. So any mutations occur in the path of this cell differentiation can develop different types of the leukemias. We use a different method to study cancer cells. So in clinically, we use morphology, immunostaining, and molecular diagnosis for the mutations. We also use cytogenetics methods. So types of the pediatric leukemias are different from types of adult leukemias. So as you can see here, the most common leukemia in the kids are acute lymphoblastic leukemia, ALL, is about 75% of the pediatric leukemia. Then you followed by the acute myeloid leukemia as about 15 to 20%, and chronic myeloid leukemia, CML, is 1 to 5%. Then you also have uncommon ones such as juvenile myelomonocytic leukemia, JMML, and mixed lineage leukemia, and chronic lymphocytic leukemia, CLL. So in terms of the ALL and the chromosomal abnormalities in ALL can define specific subgroups. And the good news is for ALL, the treatment and the survival rate is very good and is about more than 90% by now. So this is a slide to show you the basic genetic abnormalities in ALL associated with different prognosis. So in childhood ALL, you can have children and more than 1 year old infant, less than 1 year old. As you can see here, for the children more than 1 year old, you have a hyperdiploid. It means loss of the chromosomes, and usually means you have less than 44 chromosomes per cell, and is usually associated with an unfavorable prognosis in BALL. And you also can have the BCR-ABL and the 9 and 22 translocation. And the presence of this translocation occurs about 3 to 4% of the ALL cases in children. And within the initially is a poor prognosis, but by now with the current treatment approach, including the 3rd generation TKI with chemotherapy, is pretty useful for the BCR-ABL ALL patients. So then the MLL or KMT2A gene and located on chromosome 11q23. So rearrangement of the KMT2A gene occurs in 5% of the children with ALL. And also you can notice here, so in the infantile, and you can see like majority of the patients can have the 11q23 rearrangement or KMT2A rearrangement, and this abnormality occurs frequently in the uterus, so it's pretty common, and this is associated with unfavorable prognosis. So then you also have the ETV6 RUNX1. This is the 12 and 21 translocation is associated with a good prognosis. And then you also have a high hyperdiploid. So the diploid is common in the children with BALL is about 1/3 of the children can have the hyperdiploid. So you can divide the hyperdiploid into the two subtypes. So one is called high hyperdiploid, is with more than 51 to 65 chromosomes, and the other one is low hyperdiploid, 47 and 50 chromosomes. And overall, the patient with high hyperdiploid usually has a good prognosis. So then you also can have the intrachromosomal amplification of chromosome 21. So is not common. It's found in around 2% of the pediatrics ALL with BALL. And the patients usually are older, the median age around 9. And so it's very important to distinguish the true hyperdiploid and the masked hyperdiploid. So as I mentioned before, like a hyperdiploid, you have a good prognosis, and a hyperdiploid with less than 44 chromosomes with unfavorable prognosis. But you also can have something called a masked hyperdiploid, usually has not a good prognosis. So recognize the masked hyperdiploid is important. And it's also the diagnostic challenges for our physicians. So giving an unfavorable prognosis, so it is important to detect the masked hyperdiploid patients. So this is a kid and with BALL, and this is initial karyotype. As you can see here, you have 4 copies of chromosome 1, 6, 8, 11, and 19, and 21, and you have 3 copies of chromosome 10, and 12, 14, and 22, and you have some chromosomes has 2 copies, and 2, 3, 4, 5, and 13, and 15, 17, and 20. And the total number is 63 chromosomes. So, if you look at this karyotype and say, hey, this patient had a hyperdiploid chrome because more than 50 chromosomes. And, if it's truly a hyperdiploid clone, this patient will have a good prognosis. But however, certain chromosomes will be commonly gained in the hyperdiploid clone, but it's not present here. So that's why we did the SNP mic array, try to see whether this is real hyperdiploid clone or this is masked hyperdiploid clone. So the SNP mic array was performed as showing here. You can see actually the place you saw has 4 copies. Actually, they only had 2 copies, but the 2 copies doubled. And the chromosomes you saw has 2 copies, actually just 1 chromosome just duplicated. So they are identical to each other. So it's showing here. So by the SNP array, those 2 chromosomes are identical to each other. You don't have the AB allele here by SNP. So SNP mic array is useful to determine whether those chromosomes are identical to each other or not, to see whether you have a loss of heterozygosity. So then you also have some chromosomes that have 3 copies. So this 3 copies means you have initially it's 2 copies. You duplicate it, become 4 copy, but you randomly loss of another copy, so it becomes 3 copy. So at the end of the final diagnosis of the SNP mic array for that karyotype is actually the patient had 34 chromosomes. all those 34 chromosomes are doubled, but you also have a random loss of other chromosomes. So when we summarize this case, is the patient original karyotype is 63 chromosomes, and with a bunch of the gains. So based on the karyotype, the patient had a good prognosis because it's a high hyperdiploid and with more than 50 chromosomes, good prognosis. But however, after SNP microarray, the patient actually had 34 chromosomes. Actually, those 34 chromosomes just doubled. So it's masked hyperdiploid, actually only 34 chromosomes. So which means the patient has poor prognosis. And therefore, we actually changed our treatment protocol from original standard risk as a true hyperdiploid clone to a high risk treatment strategy, mainly because of the patient actually has a masked hyperdiploid clone. So the intrachromosomal amplification of the chromosome 21, IAMP21, so is an abnormal version of the chromosome 21, including multiple regions of the gains, loss, amplification, insertion, and deletions. So this shows you the formation of the chromosome 21 is pretty complicated through the breakage, fusion, breakage in BFB circles, and followed by the chronotriposis events. So this chronotriposis events is you can shadow the chromosome into the segment, then you rearrangement. So that is the very massive structure chromosome abnormalities. And furthermore, the single cell analysis demonstrated the early acquirement of IAMP21 is an early event followed by the the UV mutation signature and high mutation load, are the secondary genetic abnormalities. So therefore, we needed to characterize, map all those amplification regions is pretty useful for the informed clinical management for those patients. So Philly-like of ABL, BCI, ABL-like ALL occurs with a frequency about approach to 15% in children. It shows a similar gene expression profile to BCI, ABL, ALL, and despite the lack of the BCI, ABL fusion. So the majority of the Philly-like ALL has a high frequency of the IKZF1 alteration, leading to the TKI resistance. So among Philly-like BALL, CRLF2 rearrangement are equally common and consistent of a translocation of immunoglobulin heavy changing IgH to CRLF2. So these two, the CRLF2 IgH fusion or fusion due to interstitial deletion of the PAC1 region centromeric to CRLF2 in chromosomes X and Y, leading to the P2RY8 and CRLF2 fusion. So more than 90% of the Philly-like ALL cases have a large number of genetic changes that active genes for kinase activities showing here. So you can see you can have the pathway associated with JAK2 and STAT. You have the ABL class fusions and the RAS pathway mutations, and also other uncommon fusions as listed in this table. So patients with Philly-like BALL usually have a high risk of induction failure, MRD positive, and high relapse rates and low overall survivals. So the KMT2A rearrangement ALL are common in BALL, and especially in the infantile BALL. There are more than 100 different translocation partners as shown here. So therefore, there is a FISH strategy called the break apart. FISH strategy is useful to see whether the patient has KMT2A rearrangement. So this strategy is basically you label the upstream and the downstream of the KMT2A genes with red and green. So in the normal situation, you should see red and green and upstream and downstream and 3' and 5' of the genes will be always together, become fusion. But however, when you have a rearrangement occurs, so you will see the separation of the red and green color. So it's pretty easy to review it. So it will tell you, say, hey, whether your patient has the KMT2A 11q23 rearrangement. This is a pretty powerful method. But however, this method will not be able to tell you who is the translocation partner, especially this gene is so popular in this leukemia. So the other two recurrent cytogenetic translocations is 12 and 21 translocation leads to the ETV6 RUNX1 fusion, which is associated with a good prognosis. And also the 1 and 19 translocation leading to the TCF3 PBX1 fusion. It occurs about 5 to 6% frequency. And this subtype is, has the, favorable or intermediate risk for those patients. So the genetic factors involving in TLLL are complicated and can include chromosomal translocations, mutations, and epigenetic changes. The translocations and inversions involve the TCR genes are showing here, and which is recognized as the oncogenic hallmark of the TLLL. They are present in close about 1/3 of those patients when we use the FISH or the PCR analysis. So this TCR gene loci most often recombinated with targeted genes are TRD and TRB. So those are those genes are located in the 14q11 and 7q34. So besides the TCR genes, you also have other recurrent gene fusions in TLLL as listed here. So one thing I want to mention is this 5 and 15 translocation involve the BCL11B and TLX3 fusions, because when we run a group of the patients with another method, which I will mention, the optical genome mapping, we review the frequency actually in the TLLL is much higher than reported. And you also can have, ST, IL, and TEL1, and NUP214, and ABL, and etc. All those recurrent gene fusions in TLLL. So the acute myeloid leukemia is biologically and cytogenetics and molecularly different. And the chromosome abnormalities are very useful to classify the AML is showing here. So if the patient has APL or the 15-17 translocation or the core-binding factor alpha or beta fusions, so it's involve the 821, involve the core-binding factor alpha, and inversion 16 is core-binding factor beta. So if you present those three recurrent translocations, the patient will have the better prognosis. But however, if the patient has loss of chromosome 5 and 5q deletion, loss of chromosome 7, 7q deletion, and also have 11q23 rearrangement, inversion 3, or complex karyotypes, those are the poor prognosis. So, and for the molecular, so if you have the FLT3 mutation without the NPM1 fusion, those patients will have a poor prognosis. So one thing I want to mention is, so if your patient has a core-binding factor, either alpha and beta and fusions, so those patients has a good prognosis. But however, you really want to know whether the patient has the c-KIT mutations. if indeed the patient has secret mutations, you can see here we have moved this group of the patients, with co-binding factor fusions and secret to the intermediate risk, because those patients with secret mutations will be easily relapse. So those are the common abnormalities can use to classify those patients. So this is the older slides that show the survival curve. So if you have co-binding factors, you survive better than the normal karyotype, and also better than you have loss of 5 and 7. So then, I will quickly run through the APL, and everybody know here. And so basically it's 15, 17, and involve the PM Aurora fusion. And this is really a start case for our lab. So, so I'm on call in the new year or any holidays, mainly because of if I have this patient in my hospital, we usually do a very quick, like within 4 hours, do a FISH test to detect this fusion, and we give the patient the treatment immediately to avoid the DIC. So this is really, the start case for the cyto lab. And you also have the 2 co-binding factors. So the 821 is associated with co-binding factor alpha and involve the ETO and AML1 fusion. And then you have inversion 16 or translocation 1616 is involved the CBFB and involve the CBFB MYH11 fusions, which both are, very easy to, associated with good prognosis. One thing I want to mention is look at the 821. So this is normal chromosome 21. This is normal 8. And this is abnormal 21. This is 8. So 821 is pretty easy to see by the karyotype. But however, when you look at this inversion 16, so this is a paracentric inversion. It's pretty hard to see by the karyotyping. So then sometimes in your lab, you might miss it by the karyotyping. So therefore, the FISH is useful to detect the inversion 16. So then you also have the 911 leads to the KMT2A and AF9 fusion, and which is associated with poor and intermediate risk. And you have 1 and 22 translocation involve the IBM15 and the MKL1 fusion. And this is only half of the patients can achieve the complete remission. So the multi-lineage AML, and you always has 5 and 7. Many is the long arm of the 5 and the long arm of the 7, and those could have loss of entire chromosome or could only lost the long arm of those 5 and 7. And you also have the 3q26 rearrangement, and mainly involve the MECON and EVI1 rearrangement. So this is a paracentric inversion. It's pretty hard to see, sometimes harder to see if the chromosomes are too short. And you also can have other chromosome abnormalities. So for the +8, and it's very easy to see by either chromosome and the FISH showing here. As you can see here, gain of entire chromosome 8 by karyotype, you wouldn't miss it. And also by the interface FISH, you see 3 copies instead of normal 2 copies. It's pretty easy to review it. The second, the AML, so which means the patient could have other disease such as brain tumor. Then you treat the kids with the chemo and the radiation. You develop the secondary or treatment-related AML. And those patients commonly will have the 5q and the 7q and the deletions, and also can have the 11q23 rearrangement. And the patients with secondary AML usually have a poor prognosis. So the 5q deletion is easy to see by the FISH strategy is showing here. So you label the 5p with green and the 5q with red. And in the normal, you should see p, normal 5, and the normal 5. And it has the green and the red and the green and the red. And in the abnormal, when you have a loss of the 5q, you can see you have 2 green and for the p on, and you have 1 for the q on. So you loss of the 5q. So those are the 8 functional, groups which associated with develop leukemia in AML. And the genes can commonly mutant in the AML, in addition all those recurrent chromosomal abnormalities. So the key genes such as FLIP3, NPM1, IDH1, IDH2, RUNX1, TIM2, ASXL1, etc. So therefore, the mutation profile is also important for those patients. So the CML, chronic myeloid leukemia, really is a very good example to demonstrate the importance of the cytogenetics for our patients. So I want to show you, this slides. So this slide shows you like how we discover the CML and the 922 leads to the treatment, and so this basically a cytogenetics in Philadelphia look at the bone marrow and from the patient with CML, and she say, I think there is a translocation between chromosome 9 and 22. And so this is always present in the patients with CML. And then, so they call this translocation is a Philadelphia translocation. And the key player later on we know is this small chromosome, derivative chromosome 22 involve 9 and 22 translocation. So this small chromosome is called the Philadelphia chromosome. So this Philadelphia chromosome had the BCR-ABL fusion, express a fusion oncoprotein with tyrosine kinase activity. So we spend years to, understand the molecular mechanism and develop the tyrosine kinase inhibitor to kill the cancer cells. And also we developed a specific called the dual fusion, dual color FISH strategy to detect this fusion and use it as a follow-up and treatment after treatment to see whether you have residual diseases. So this basically is a good example to demonstrate from the basic cytogenetics findings for this translocation to find the molecular mechanism leads to the treatment for this disease. It's a very successful story. So then you also have not very common diseases such as JMML, and this disease can share both, AML and myeloproliferative diseases. And usually those patients can have the certain inherited genetic syndromes as shown here. So you can see you can have MF1 neurofibrosis type 1, and the patient mutation in the MF1 can associate with the risk of the leukemia, such as JMML, and the CFC syndromes and associated RAS, MAC-K signal pathways, especially the KRAS mutations can associate with JMML. And you also can have Noonan syndromes, Kossler, and Lapid syndromes can associate with JMML. And it's not a common disease, but it can happen. And also we all know like other genetic syndromes can also associate with specific leukemia, such as we all know Down syndrome. The Down kids can develop the ALL and AML, and the lymphomania syndromes mutations in the TP53 can lead to the AML and ALL, and the Fanconi anemia is especially can develop high risk for the AML M4 disease, M7 diseases. So there are common types of the children's leukemia as showing, lymphomas as showing here. So for the children, you can have Hodgkin's lymphoma and non-Hodgkin's lymphoma. So the Burkitt lymphoma and associated with EBV virus infection can develop rapidly in the areas such as jaw and the facial bones. So this shows you the examples how we can, using the FISH to detected the fusions and detected the rearrangement. So the Burkitt lymphoma is an aggressive B-cell lymphoma and always can be linked to the chromosome abnormalities associated with the MYC genes on chromosome 8q24. So this 8 and 14 and translocation is the most common genetic abnormality in both the lymphomas and associated with the IGH and the MYC gene fusions. And so, of course, you also can have other fusions such as chromosome 2, chromosome 22 also can lead to the MYC overexpression. But however, the 8 and 14 usually is a hallmark of the Burkitt lymphoma, mainly because it's more common. So the way we design it is, we have both break apart fission strategy and also for the dual fusion for specific gene fusions for the 8 and 14 for the MYC and the IGH. So the initial we'll screen for it whether the patient has MYC rearrangement first. So the same principle, you label the upstream and downstream with red and green for the MYC gene. So normal should be yellow, separate the red and green should be, rearrangement. In here, you can see this from the lymphoma, and you can see, this cell had a one fusion here is normal. One fusion here is normal, but however, you see the separation and the red and the green, and this shows you an rearrangement of the MYC. And then we will follow up, try to figure out which, whether it's 814 or 28 or 822 or etc. leads to this specific the Burkitt lymphoma. So you also can have other translocations in lymphomas such as anaplastic large cell lymphoma, so ALCL, and this is a T-cell lymphoma, and the classical fusion is ALK, and the NPM1 is 2 and 5 translocation. So you can have this ALK positive, ALCL, and ALK negative ALCL diseases, and associated with different mutation, different pathways. And the follicular lymphoma is associated with BCL2 rearrangement, and the classical fusion is 14 and 18, and BCL2 and IGH. And then you also can have aggressive B-cell lymphoma, and such as, in the older time, we call it double hit or triple hit. So basically associated with the MYC BCL2 rearrangement. So the patient will have both MYC rearrangement and BCL2 rearrangement, leads to the double hit, which is associated with aggressive B-cell lymphoma. So we also do a lot of cytogenetic studies in the pediatric solid tumors. And this shows you, some common pediatric solid tumors in the lab. So you can have the M amplification in neuroblastoma, which is most significant genetic markers for the poor prognosis in the patients with neuroblastomas. It's see about 1/4 of the high-risk neuroblastoma patients. And rhabdomyosarcoma is also the common soft tissue sarcoma in children, and from the muscle tissues. And the hallmark of the translocation is PAX3 FOX1. And occasionally, we also can see the PAX7 and the FOX1 and fusions. So the Williams tumor is the most common kidney cancer in children, and usually occur in the children less than 5 years old. So we usually can see the MT1 gene deletion, and the mutations are common in Williams tumor. So Ewing sarcoma is a highly aggressive bone and soft tissue cancers. And the classical translocation we see is EWSR1 FLIP1 translocation, which is a hallmark of the Ewing. But however, Ewing also can have other translocations such as ERG and all the other, very low frequency other genes. So osteosarcoma is pretty interesting. It's the most common bone cancer in children. And we commonly see RB1 gene mutation and TP53 mutation, and also complex karyotypes. So then you also can have the retinoblastoma is a malignant tumor of the retinal and is the most common eye cancer in children. So the RB1 gene mutation and the deletion are common in this disease. Medulloblastoma is a common malignant brain tumor in kids. And the patient will usually you will see the loss of heterozygosity of the 17p and the core deletion of the 1p and the 19q, and also the MYC amplification. So the MYC amplification is a poor prognosis marker in this disease. So I want to show you some examples and how we do the solid tumors here. And also I want to show you another new tools and another new method we are using for the clinically here for our patients, besides the other three methods I mentioned before. So Ewing sarcoma, so this is 10-year-old female with Ewing sarcoma. And, so you see here the morphology show the nice blue cells and small blue cells. And the karyotype is showing here, the patient has a classical 11 and 22, and this is consistent with Ewing sarcoma. And furthermore, the RNA gene fusion assay revealed EWSR1 FL I1 fusion, which is consistent with this diagnosis. So then you also can have another case like here. This is 7-month-old boy with shoulder mass. We did a karyotype, but however, the karyotype show a normal karyotype, which is common when you do the solid tumors, because the solid tumors sometimes they refuse to grow or the cancer cell cannot grow in vitro. But however, we do have a fish. So we do a break apart the fish. And you see the EWSR1 rearrangement is showing here separation of the, the upstream and downstream of the EWSR1 genes. But however, it's pretty cool. You say, okay, the patient has EWSR1 rearrangement, but however, we don't know who is the translocation partner. So then we did the optical genome mapping called OGM. So, and revealed that this patient actually has 7 and 22. So this is chromosome 7, this is 22, this is the patient sample. You can see some reads from 7, some reads from the 22, they present together in the patient sample. So which means this translocation leads to the fusion of the EWSR1 and the ETV1 fusion leads to the diagnosis. So, so what is optical genome mapping? So due to the limitations of those three traditional cytogenetics methods, so optical genome mapping (OGM) has become as a promising method to detect genome-wide structure variants (SVs) and copy number variants (CNVs). Through the optical mapping of extremely long linear molecules. So this shows you the setup of the OGM is pretty simple. It's very similar to that of the SNP arrays. So you have a kit to label your patient sample and chip to load your sample and your scanner to scan the chip and the computer to do the analysis. So the core technique of the OGM is based on nanochannel array as shown here. So those nanochannel arrays are very narrow. So only a single DNA molecule can pass through. So those single DNA molecule with green fluorescence label can provide genetic information. So the distance between here and here, between those fluorescence labels generate unique genomic data that are essential to review genetic variants. So this shows you the example and the beauty of the OGM. So basically, in here, the patient is the blue and the normal reference is green. So when you compare a patient and the normal, and you will see whether you have a gain and the loss of genetic material. And also you can see any balance as whether you have a structure of abnormalities such as reciprocal translocations or inversions, insertions. So this method is useful mainly because of the SNP microarray, because of the method only can detect whether you have imbalanced genomes or gain and losses, but it will not detect any balanced structure of abnormalities such as translocations. But however, this method actually will detect both, the gain and the losses, and also the balanced structure of anomalies such as translocation 922, BCI-ABL, etc. So therefore, this OGM has a great potential to be widely adapted in the cytogenetics lab. So in here shows you the OGM compared to the chromosome studies. So both methods can detect both structure variation and the copy number variations, gain the loss, and also structures. But however, the OGM is about 1,000-fold more sensitive to detect both CNV and SVs, has great potential to adopt in the clinical lab quickly. So this shows you that examples how OGM is useful when we have very difficult cases such as solid tumor. So this is malignant peripheral nerve cell tumor, MPNST, and as you can see here, the patient has a complex karyotype and near tetraploid and numerous chromosome abnormalities. So the OGM, the circles plot shows you have a loss of SVs, structure variance. So each line here actually is one structure variance. So this is the circle plot and shows you by the OGM, you have loss of SV. So then this is the copy number plot, CNV plot. You try to see whether you have a gain and the loss across the genome. So the red is for the loss and the blue is for the gain. You can see you have many gain and the loss across the entire genome. So therefore, the OGM is pretty useful to review the complex genomic alterations in solid tumors. So we performed the OGM on 60 bone and soft tissue tumors and many pediatrics tumors. And we compare the result, the OGM result with the traditional karyotyping in the fish. And also we have the gene fusion assay based on RNA sequencing and also deep sequencing, and to see, what kind of things we can see. And the result is a very surprise to us, mainly because of, you can see here, have a bunch of the changes in all those samples. And furthermore, we see many complicated rearrangement. So then a classical sample is a reciprocal translocation between one gene to the other gene, but then we also see unbalanced three-way translocation, balanced three-way translocation, and 4-way and 5-way translocation and the 6-way translocations are common in the bone and the soft tissue sarcomas. So I gave you an example to show you this is 14-year-old girls with a lake mass and with a complicated karyotype is showing here. And the karyotype shows the patient had a 5 and 12 and 12 to 22 and 22 to another 5. And this is a 4-way translocation. And also you see, have a, abnormality involved chromosome 13 and 16. And the OGM actually reviewed the patient at the 6-way translocation. So from chromosome 5, from chromosome 5 to 22, 22 to 12, 12 to 5, and 5 to 16, 16 to 13, 13 to another 5. So which means it shows here chromosome 5, 12, 12, 22, 22, another 5, 5 to 13, 13 to 16, and 16 to another 5. So, and this is so many genes involved, this, this 6-way translocations, and the key player is ATF1, EWSR1 fusion, and leads to the diagnosis for this disease. But however, all the other genes, whether play the roles for, for this disease, and it's pretty interesting to know in the future when we have more of those data. And furthermore, the clonal angenesis events are common in the bone and soft tissue and tumors as showing here. So 1/4 of those samples had the clonal angenesis events. So the chronoangenesis is from the Greek words, means chromosome reborn. And you can have a different mechanism, chronotropism, chronoanasynthesis, chronophylix. But anyway, you can lead to the complicated chromosome abnormalities. And in here shows you, and all the osteosarcoma we studied by the OGM all had different types of the chronoangenesis events. And interestingly, with the chromosomes 8 and 16 and 17 are the most frequently involved in the chronoangenesis events in the osteosarcomas. So exploring the role of the chronoangenesis may shed a light on the mechanisms underlying cancer formation, particularly to the identification of the new cancer biomarkers. So this is summary shows you compared to karyotype and OGM. Karyotype is in your left and OGM in your right. And as you can see here, the 75% of the samples we can, get the abnormal, but the 25% we will not see. We get the normal karyotype and the field karyotype, but however, all those samples, the OGM can reveal diagnostic and pathogenic SV and CNVs are important for the diagnosis, prognosis, and treatment. And furthermore, the OGM identified SV and CNVs in 18 specimens. So 1/3 of this study and could potentially influence treatment decisions. So I will end my talk use this iceberg. So our current knowledge of the biomarker could be still at the tip of this iceberg, especially for the solid tumors. So we have, the karyotype and the FISH and the SNP microarrays. Those are the traditional cytogenetics methods. And with the further development of the OGM, accumulate more data from the OGM and also RNA sequencing and the deep sequencing, whole genome sequencing, and along with the protein profiles and the methylations, we will begin to discover more biomarkers, which may be useful for our patients for the diagnosis, prognosis, and treatment. So I will end my talk here. Any questions?
Any question to the prof? You can raise your hand and you can ask the prof question. We have prof few minutes for question. We'll wait. Okay, Wala, you can.
Yeah, I saw lots of questions on the chat.
So question in the chat.
Yeah, because it's like a 21 but I'm not sure.
No, this is the chatting later. There's no
okay,
question
cool.
in the chat. No, sorry, prof. And there's any question from participant? Okay. Thank you so much, Prof, for extensive lecture about cytogenetic and molecular in children with cancer. I'm always have difficulty to remember all these numbers and cytogenetic and rearrangement, but you make it very easy for us today in one slide, and special for the solid tumor and for hematological malignance. I appreciated your time and your dedication and your support for the first session. It was a great lecture today, and we have more than 100 participants today, and it's about 120 exactly. I think we have one question. Please, can you explain interpretation of FISH?
So interpretation of the FISH is very, very tricky, mainly because of, as a cytogeneticist, every 9 months I review the normal cutoff for the FISH. So basically, the way you read the report is, you always, read the conclusion or interpretation. They will say whether you see this abnormality or you don't see, it's positive or negative for this abnormality first. So then they will explain how we did it. So as I mentioned in the lecture,
Mhm.
you have a break apart fish probe. They say we use a break apart fish probe. We see this gene rearrangement or not, you know. So they have a normal cutoff for the other things, you know, but for the physician, they only read whether you get the, you know, positive and the negative result. That's all you needed to know, you know. But sometimes if you have
Mm.
not a typical one, then they will mention it. But you know, however, you know, if it's a typical one, you definitely say this patient has a gene fusion or gene rearrangement. But a typical one, so which means not a typical pattern we are seeing it. So this in those cases, then in the report, in the interpretation, they will mention is they say we did this, we found this not a typical pattern, but a typical pattern, and unusual findings. But they always ask you say correlation with other result, clinical presentation is recommended. So that is important to you communicate with your cytogenetics to say whether this result makes sense or not. You know, yeah. But
Okay.
feel free to
Okay.
email me if you have any
And
questions.
yeah, if you have any question, you can contact the prof directly. Okay.
Mm.
We have end of the session. Thank you so much again for your time. Appreciated your dedication and support. I'll just reminder for the participant, this is the serial lecture launched by Cyber Africa Education and Training Community, focusing about basic pediatric oncology. It's starting today, the first day from 15th of January until April, every Wednesday, except Sunday, we have the lecture with Dr. Sally, Professor Sally from Egypt. And every time will be by 7 p.m. Central African time. Please, just I would like to invite all the participants to enjoy this lecture and believe this opportunity to strengthen our knowledge and skills regarding pediatric cancer management and encourage your colleague to attend. And all the participants achieved attendance 80% or more, they will get certificate. And there is the form, registration form you can fill and email it. And thank you so much again today for your time to be part from this session. And we'll see you in Sunday the same time by 7 p.m. by Central African time. Thank you so much, Prof. Again. Thank you for everyone.
Thank
Bye.
you. Happy New Year.